Thank you for the invitation. It's been a great pleasure being here. These are my disclosures. So we're going to talk a little bit about myocardial infarction. And as we've heard before during this meeting, is that cardiovascular disease are a very common cause of morbidity and mortality. It is the #1 cause globally, but also in the United States. So these are the 2025 numbers for heart disease and stroke statistics from the American Heart Association. And we do see globally and in the US a massive number of cardiovascular deaths. And we do see a lot of it. 25% of US adults have high LDL. 3.65 million deaths globally were contributed to cholesterol. So those are things we're going to talk about. We do need to also talk about the fact that many first myocardial infarction occur in patients without prior symptoms. So this is a recent study. It's done on US claims, so on patients who have their first myocardial event between 2017 and 2022. So it's over 4.5 million patients. And they looked at their risk factors and their physician appointments. So about 18% had no documented SMRFs. So SMRFs are modifiable risk factors, such as smoking, high cholesterol, high blood pressure. So 18% of people with myocardial infarction had none of them. 51% had no documented symptoms. That doesn't mean they didn't have symptoms, they were just not documented. So either patients didn't recognize them or they didn't have them. 22% of these patients had no prior physician visits. So their first visit was during their myocardial infarction. And 63% was not on any preventative drugs. So these numbers also mean there's a lot to gain in these patients for early detection. We do have to realize that early detection is not solely about predicting events, it's identifying patients with high-risk biology. These are numbers from 2022, where we do see ischemic heart disease as the #1 disease of cardiovascular deaths by cause. So it's ischemic heart disease, ischemic stroke, and intracerebral hemorrhage. Those are massive numbers, but if we look at the global ranking of attributable burden of cardiovascular disease due to selected modifiable risk factors, we do see it's high systolic blood pressure, dietary risk, and cholesterol. So those are the modifiable risk factors. And when we look at early detection, we very often also look at those markers to intervene on. So when we look at myocardial infarction, very often we talk about atherosclerosis, plaque burden. So there are different pathways for plaque development, and plaque development is a gradual disease, but we do see plaque rupture, which causes very sudden myocardial infarction, is a more sudden process, also plays a very big role in myocardial infarction. Since 50% of myocardial infarctions are caused by non-obstructive vulnerable plaques instead of the obstructive atherosclerotic plaques. What we have learned in the recent years is that plaque develops most of the time from soft plaque with vulnerable features to calcified plaque, which is considered more stable and less prone to rupture. We also know that by giving statins, we increase calcified plaque and we tend to stabilize some of these plaques, make them less vulnerable for rupture, but this can affect things like your calcium score. It's good to realize by the time myocardial infarction occurs, these patients have had atherosclerotic disease probably for decades or at least a decent amount of years. So there's time to intervene as long as you're early. I'm trying not to get into the discussion of who should be on statins because I'm not a cardiologist, but that is what this discussion very often leads to. We do have to think about traditional risk factors that are not equivalent to plaque burden or plaque instability. So that's why we talk about our traditional risk assessment. There is a bunch of scores, the Framingham risk score, the pooled cohort equation, more recently the PREVENT score. They're developed on very big cohorts, and very often they predict 10 or 30-year disease for atherosclerotic events. They contain very often age, sex, high blood pressure, smoking, cholesterol. Some of them include BMI, race. In the recent one, we very often see more of the cardiometabolic, kidney function, all of those in there. they do reasonably well. We have to keep in mind their risk factors. They don't look at the actual disease. They're population-based. They tend to underperform in women, younger patients, and diverse populations. And many patients who are at intermediate risk will still have events. There are even patients who have low risk, as we saw in the earlier slides. 18% had no risk factors. They will score really low on these risk scores, but will still have myocardial infarctions. So when we look at tools for early detection, we're going to talk mostly in relation to lung cancer screening, so about imaging markers. One of the most well-validated one is calcium score. We've talked about it a lot already, is that we know a calcium score of 0, you have very low near-term myocardial infarction risk. I do want to emphasize that a CAC of 0 doesn't mean you have 0 risk. It means you have a very low risk. There are still patients with a CAC 0 who will have events. It is very low, but we do see it more in younger patients or patients, for example, African-American patients, where the CAC 0 doesn't seem to work as well as in other populations. It is a very strong prognostic factor, even beyond the traditional risk factors and risk scores. What I wanted to specifically mention, these are the no SMRF patients. So these patients have none of the risk factors, non-smoking, no high blood pressure, no high cholesterol, no diabetes. Even these patients, when they had MIs, had significantly higher calcium scores than patients without MIs. These patients will never show up in screening cohorts because they have no risk factors. So this would be an argument to say, hey, maybe we should screen everybody independent of risk factors, but that's a whole different discussion. This is some of our Emory data. So this is on 7,500 asymptomatic individuals that got a calcium screen. At Emory, we often do these wellness screens and they get calcium scores. So these are patients with no symptoms. They do have risk factors very often though. So 41% were women and 29% of this population was non-white. And we compared their calcium scores in their PCE risk groups and the PREVENT risk groups. So we see on the left, we see like the low risk group below 5%, the intermediate, and then the high risk groups. What we do see is that in the low risk group, below 5% for both PCE and PREVENT, we see that around 50% of patients have an above 0 calcium score, and there's around like 11-12% that have a calcium score above 100. That's a decent amount of patients that you would give, according to clinical risk scores, a very low risk. If we look at the opposite, at above 20%, we do also see that 12-13% who have very high clinical risk but a 0 calcium score. And this can, of course, also be age-related. So how early detection changes management, and then we're talking specifically about CT. We do see that CT-guided therapy, we see a higher statin initiation, but we also see a higher patient adherence, as shown in this study, is motivational effects of coronary calcium scores on statins, and these are all a little older studies, but we do see when patients actually get a calcium score, they tend to take their statins better or goes on a statin earlier than when they only get their traditional risk scores. We also do see that lifestyle modifications are more effective when disease is visualized. And we do, and I think we saw this graph earlier, see lower rates of myocardial infarction in appropriately treated high-risk patients. So this is in an ARMY study, but we do see if you have a 0 calcium score, it doesn't matter where you take statins or no statins, but if you do have a positive calcium score, it does matter where you take statins or no statins for the myocardial infarction. So calcium score can help appropriately treat patients who have an above 0 calcium score. I want to emphasize that early detection enables earlier statins or lipid-lowering medication, blood pressure control, and lifestyle changes, which leads to fewer MIs. So if we look specifically at coronary artery disease leading to MI in lung cancer screening populations, so this is data from the NLST trial. CVD was, with 25%, the leading cause of death among trial participants, above lung cancer and other cancers. In 32 studies, this was a review. In 32 studies, the CAC prevalence varied from 14 to 98%, depending on grading scheme and classification. So there is a lot of coronary artery disease in these lung cancer screening populations, as expected. So if we look, for example, here at the qualitative coronary calcium reported, we do see a very decent amount of calcium scores, even severe, up to like 10% in numbers. I want to talk a little bit about AI involvement, because that's what I normally do. We do see a lot of AI algorithms specifically for chest CT. Part of it is so we can correct for some of the motions or the non-optimal for coronary calcium screening image protocols, but also to deal a little bit with the increased burden on radiology and cardiology departments. So we do see a lot of work being done that AI can do this automated. There is a little bit of a struggle, and I think people here would recognize that if this is done automatically and it ends up in the report, there needs to be a step after the report. You cannot just put it in the report and not do anything with it. And we do see a lot of work being done, especially in the US now, where there are automatically notifications. So if the report notifies, hey, there is an above 0 calcium score, an automatically notification goes to either the GP or the cardiologist, say, hey, check up with this patient. And I think that's going to be essential in some of these processes. And we do see also that we can do it now on PET, so not only chest CTs, but we do see a lot of calcium score also on all these other exams. We are even starting to do it on chest X-rays, where we can see some of the calcifications with AI. I think we need to... So if we look at chest CT specifically in therapy, so there are some studies who looked at does therapy change based on calcium score on these chest CTs. So if we look at this study, it was like 74% of screened patients were eligible for statins according to the ACC and AHA guidelines. These are the old guidelines, not the guidelines from a week ago. But 60% of these patients lacked any prescription before CAC detection, and changes in management were observed after CT imaging in 20% of patients. It's not surprising that changes in management were more common in those without established coronary artery disease, but it was also more common when CAC was semi-quantitatively graded instead of non-quantitatively. So this is another study where over 2,000 patients with non-gated chest CT, no ASCVD and no statin prescription. So again, they showed after 6 months an increase in statin prescription in these patients. The statin prescription rate was 51% in a notification arm versus 6.9% with usual care. So that is a decent increase in statins. We do also have to look a little bit at follow-up testing after these calcium scores. So we do see in these patients, when they get a calcium score, especially when the calcium score is above 0, we do see a slight increase in their stress testing. So some of these patients got stress testing based on their calcium score. That is something to discuss for follow-up treatment. So there are some limitations of calcium score. So this was a 38-year-old male that we saw in our hospital, had atypical angina for 2 months. They prescribed a PET perfusion test, which came back negative. We did a calcium score on his attenuation correction scan, which came back as 0. Patient kept having chest pain, so we ended up doing a CTA, and this patient had a non-calcified plaque causing an 85% stenosis and got a stent 2 days later. And this is one of those cases why we do CTAs in patients with symptoms and maybe not a calcium score. So CT angiography has been in the guidelines for a few years for patients at intermediate risk. It detects non-obstructive plaque and high-risk plaque features, so it can also help detect those cases with vulnerable plaque that get plaque ruptures. There's many studies, Scott Hart promised, that show like earlier diagnosis, it changed management, and there are fewer downstream MIs. And I know this is not an option in a lot of the lung cancer screening trials because of the contrast and the gating, but we do see a lot of plaque quantification in these studies. There's massive amounts of investment in plaque quantification with AI. We do see reimbursement for it in the US. It's all powered by AI. I have no doubt that in a few years, they're going to try to do this on non-contrast scans and create AI algorithms that convert non-contrast CTs to contrast CTs and do some of these plaque analysis on non-contrast scans to at least see if patients have non-calcified plaque, because we do see in about 30 to 40% of patients with non-calcified plaque in specific population, we do see non-calcified plaque. These are a few studies, and I'm going to go through them really, really quickly, that show that plaque volume predicts future MI. And this is total plaque volume. These are different types of algorithms. So maybe the volume thresholds are not generalizable, but we do see here that total plaque volume predicts MI a lot better than obstructive stenosis or assigned scores. But we also see in these studies that adipose tissue and inflammation plays a role. We heard a little bit about EAT, but we also specifically look at pericardial adipose tissue, which is the EAT around the coronaries, which can be a sign of inflammation even before a plaque is developed. So we measure it by measuring right around the coronary. This is from the Orphan study, so they did a global analysis of PCAT in these patients, and it showed that it is predictive of death and MI, even above, like on top of the regular plaque volume score. So it is an independent predictor. And there are studies that now actually are doing PCAT on non-contrast CT. We're definitely not there yet. We've been trying it. There is a lot of work to be done, but if you could do this in addition to your calcium score on your chest CT, you could have a measurement in these patients with either 0 CAC or very low CAC scores that indicate whether they are vulnerable for plaque development or plaque progression. So that was my talk. As a conclusion, MI is often the first manifestation of silent disease. Traditional risk scores miss subclinical atherosclerosis, and early imaging tools can help refine MI risk. And detecting disease earlier can help targeted intervention and prevention and reduces events. Thank you.